Hi, I'm Nancy Kerber, and I'm the Executive Director of the WNC Birth Center.
And I'm Kelly Heiner, the Office Manager at the WNC Birth Center. WNC Birth Center is an independent, freestanding nonprofit birth center located in downtown Asheville. We are governed by a board of directors.
And we welcome you today to our virtual orientation. We are going to give you a little overview of what it's like to birth with the Birth Center model of care. So, WNC Birth Center opened in July of 2016, and to date, we've assisted families with approximately 675 babies. We are nationally accredited by the Commission for the Accreditation of Birth Centers, and in addition, we've been supported and mentored by the Women's Birth and Wellness Center in Chapel Hill. They've been in existence for over 20 years and have delivered 7,000 babies, and we consider them our sister birth center.
What is the midwifery model of care?
The midwifery model of care is different from the medical model of care in that it really focuses on the woman and building a relationship with her, on learning what's unique to her with her history, with her education, with her family structure, with how she is dealing with her social circumstances, whether she's have in a high stress job or whether she has a work schedule that's enjoyable to her. We are very inclusive with family. We welcome a lot of questions and conversations so that they can build that relationship. Our goal is always to provide unbiased information that includes complementary therapies and techniques and provides an environment where the women have access to all the information that they need in order to make good decisions. We are focused on patient-centered health, and we are really committed to patient-centered care with shared decision-making. We are part of your birth team. We don't dictate to our families what's going to happen. We offer whatever options are available in any kind of maternity care setting, but then we talk about what things are really necessary for each individual, and the family makes a decision about what course of care they want to have. Now, having said that, it's really important that the birth center maintain a standard where we make sure that the folks that are here are low risk and that we're abiding by the standards set by our accreditation agency. If there's complications that arise, though, our midwives have full practice privileges at Mission Hospital, and they are very skilled and trained to be able to seamlessly manage those transports, and they have access to everything that the medical model of care has to offer. And so when it's appropriate, they are very, very adept at being able to transition and blend those models together.
They are. How many midwives do you have on staff?
We have 4 certified nurse midwives, and each one of them brings with them a completely different life experience, but all of them are very knowledgeable about birth in varied settings. We are really blessed here to have midwives that have practiced in a wide variety of settings from, many places in the U.S. to international sites, and urban and rural in developed locations, as well as places where there were very few resources. And so they are really quite nicely positioned to be able to offer out-of-hospital care as well as transition into the hospital when necessary. Each midwife possesses the same philosophy that we have here at the birth center, and they are very skilled in being able to work in all kinds of environments where those unique opportunities present themselves.
Is the birth center safe?
That's a very good question that we get a lot too. Birthing in the birth center is like having a home birth. In fact, we like to say that you should plan on having a home birth. You're just having your baby at our house, where we have everything centrally located here, and we have easy access to the hospital. The hospital is only 0.7 miles and it takes about 2 or 3 minutes to drive there. So, it is an out of hospital setting. So, a lot of people wonder whether or not that's a very good decision to make as a person that's considering where to birth. So, the Centers for Medicare and Medicaid have recently concluded the study that they did called the Strong Start Initiative, where they looked at varied facilities all over the United States. 47 birth centers were included in that study, stretching over 22 states, and they concluded that birth centers provide excellent, high quality care at a low cost. And so we were very happy to have that data to be able to report. The Women's Birth and Wellness Center actually was a participant in that study. There's been other studies over the years that also have looked at what the safety level is with regard to hospital birth versus out of hospital birth. And they've all concluded that place of birth in of itself is not really an issue with regard to safety, but that there are a few parameters that you have to keep in mind in order for that to be true. One of which is that you have to have a low risk mother. And so we have a set of standards as far as what types of things we would agree to be able to consider normal for birthing in the birth center, and those which we would recommend that they birth in the hospital. Also, the other thing is you should have trained attendants. And when I say trained attendants, I mean those that are specifically trained in dealing with birth in the out of hospital setting. They're hospital and home and birth centers, they're completely different from one another. And if you're going to birth in the birth center or at home, you really have to be trained specifically for that setting. So our view is yes, birth center care is very safe, and we do have room at our inn.
Mm-hmm. What if all of the birthing rooms are full?
Yes, this is our number one question that we get all the time.
Yeah.
Is what happens if I go into labor and all these other people are going into labor at the same time? Well, we want to reassure you that even though we have people that are due at the same time, it's not that common that they're all delivering at the same time. We might have some folks that are in labor here together. However, it's not that common that they're birthing simultaneously. So it's not an issue that really comes up very often. In fact, the Women's Birth and Wellness Center in Chapel Hill, they also have 3 rooms, and they deliver about 500 babies a year, and they don't typically have that problem either. So they've reassured us that 3 birth rooms is a good size of rooms to have here. If there should be simultaneous labors, the midwife is always assisted with a nurse, so there's a team of a midwife and a nurse there all the time. And so women usually, if they are in labor at the same time, are not at the same place in their labor at the same time. And so the midwife and the nurse can tag team between, filling those needs. And in the event that it gets really, really busy, then they can call in a second call midwife. We also have a second call midwife that's available every day too. I want to say right from the outset that midwife means with woman. And so we take that really, we really take that seriously here at our birth center. Our midwives really develop that trusting relationship with folks, and that then is transitioned into how they are able to support each woman during the birth. And so when we are having someone in labor, we want to be able to give that woman as much of our attention as possible.
All right, so how often do you recommend seeing pregnant women for visits?
Okay, that's another good question. We, at the birth center, we operate on typically the traditional, conventional schedule of every month up until 28 weeks, then every 3 weeks in that 8th month or 7th month, and then as we get into the 8th month, every 2 months, or every 2 weeks, sorry, and then at 36 weeks, every week until delivery. Now, there's never been any research that's shown how many visits really constitute good prenatal care. We believe strongly that our moms need to be seen on a regular basis. We really feel that relationship building is very important, And we also really want to keep an eye on whether there's any kind of subtle indicators that could be developing along the way that, unless we saw our moms on a regular schedule, we wouldn't be picking up on. But we are in unprecedented times here, folks, with the COVID-19 pandemic. And so we're paying very close attention to national, state, and local experts in what their recommendations are. And so things at the birth center have had to change a little bit. We hope that it's only temporary. We don't want these changes to affect our personalized one-on-one care that we give. But so all practices are going through some changes right now and making some, different alternative courses for prenatal care. We will still have in-office visits for some of the prenatal care. However, we will also be using telemedicine visits, and you may be hearing some about that on the news. These are visits that are done over the phone, or there's some software that's available that can assist with that. So we are going to be seeing our patients with both types of appointments right now. And stay tuned for more information about that, because we're all just getting our feet wet in it. Things change day by day, and so we haven't really decided, how we're going to do all that, but we will do a combination of in-office and telemedicine visits.
Well, since you brought up the new restrictions, can my family come to my appointments with me?
Under normal circumstances, one of the hallmarks of midwifery model of care is that family inclusion. That is a really strong point that we emphasize, and we feel is very important to welcome anyone to a prenatal visit that the mother would like to have. And we hope in the future that we can return to that. However, during this time, all medical facilities are really restricting who can come in for appointments. And sadly, we're having to make those decisions as well. We hate to, seem harsh about it, but right now, our first and foremost priority is the safety of our moms and our babies and our staff. And so, unfortunately, right now, we can only welcome the patient to the prenatal appointment. Family members, partners, children, they just need to either wait in the car or stay home. However, that doesn't mean we want to have these visits impersonalized. And so we welcome FaceTiming, any kind of way that we can still include the family for the appointment. We are very eager to have that still happen, so we can still include family in on listening to the heartbeat and participating fully with questions and sharing concerns and whatnot. And we want to get to know the kids so that they view the midwives as a friendly extension of their family.
Do you draw labs here?
Yes, we do. We have a relationship with LabCorp. Kelly actually prepares the labs to go out every day. And so we have both LabCorp and Mission Labs when we need to use those as well. And so a courier comes to our office every day and picks up those labs, and then they return the results through computer, the same that happens in other practices. And we also have access to the same labs that you would have in a more conventional setting. And the midwife goes over what labs are typically recommended during pregnancy, which labs we absolutely have to have in order to be able to really determine that this pregnancy is normal all the way through, and which ones we can be a little bit more flexible about, or maybe administer in a little alternative way depending upon how the family feels about it. We talk about cost, and for some family members that's an issue. So again, we approach labs with the same attitude as everything. But yes, you can have genetic screening here. That we do glucose testing and all the different things.
What about ultrasounds? Do you do ultrasounds here?
We don't. We so sorry to be so blunt. We don't do ultrasounds at the birth center, but we do recommend that everyone have at least one scan during their pregnancy. And preferably those scans are done over at MAHEC. Now, if somebody lives some distance away and that's going to be really put them in a hardship to drive that far, then you can get us to order those at any imaging facility that might be closer to you, but we don't do any ultrasounds here. Do you have to have an ultrasound? No, you do not. We recommend having at least an anatomy scan that happens around in the middle of the pregnancy, and that can be very useful for us and for you as well. But we do have some families that do reject that suggestion, and we honor their right to make that decision. Having said that, should there be any indicators that come up prenatally that we might have to have an answer to in order to be able to continue to determine that that pregnancy is continuing normally, then we may need to say, if ultrasound's the only way we can get that answer, we may have to say, in order to birth at the birth center, we really need that information. But for the most part, we do everything we can to really dovetail what our needs are, taking into consideration and respecting the family's views. That's shared decision making, and our midwives are patient advocates as well.
Mm-hmm. Is there a timeline boundary for when I can have my baby at the birth center?
Yes. Term pregnancy is considered from 37 weeks, which is 3 weeks before your due date, to 2 weeks after your due date. So that's 37 to 42 weeks. 5-week window where that is viewed a normal pregnancy. Should you go into labor prior to 37 weeks, we may be seeing a degree of prematurity that may also include immature lung development, and so that would not be something that you would want to be having at the birth center. After 40 weeks, there is some degree of placental insufficiency that possibly can occur, and unfortunately, as it is occurring, it's not that easy to predict it. So it's recommended that women that are going past 40 weeks have some increased testing, some increased surveillance along the way in those next days and weeks. Once somebody is 42 weeks though, we really can't do the birth at the birth center. It doesn't mean that you have to be induced. Sometimes there will be a recommendation for induction. However, again, with shared decision making and patient advocacy, we take very carefully what your feelings are about this. The midwife has strong discussions with our families who face that challenge about what cautions there are regarding it, what options there are for possibly encouraging the body to go into labor more naturally, and recommending those additional tests that we can confirm that the baby's doing well during that time period. Should the mother not go into labor before 42 weeks, then we would recommend an induction in the hospital. However, again, this is a choice for the family to make. We cannot make anyone have an induction at the hospital at a certain point. All we can say is that you can't give birth at the birth center after 42 weeks. Some women feel really strongly about not intervening in any way, and we respect that. And other women really want to be very proactive in doing everything that they can to get their baby in labor, their body and their baby in labor before that, boundary or deadline comes about. And so the midwives have a lot of suggestions with regards to that, some of which involve other complementary therapies and referrals to alternative care providers. It may involve some herbs and homeopathic remedies. There's a lot of tools in the midwife's kit that she can, discuss with families, depending upon what their comfort level is and what their familiarity is with those.
Can I choose which midwife I see for my appointments and to have at my birth?
Yeah. No, I'm sorry, you can't. The reason for that is that we have 2 midwives on call every single day. And so there's no way to really be able to limit that midwife to a set of clients' schedules. If we did that, she would never be able to have a day off, or if she got sick, it'd be very difficult. It's just really not possible in this setting. So what we really try to do is be able to schedule those appointments in a way that you can meet each of the care providers so you can develop your own relationship with them. One of the challenges with that is that we may not be able to be so flexible that we can take into consideration nap time. We can take into
Right.
consideration the, dad's work schedule and the mom's work schedule too. Um, all that has to dovetail with the availability of what days that midwife is going to be in the office. So some of whether you get to form a relationship with each midwife depends upon how flexible your individual family situation is in order to be able to adapt your schedule to make sure that you can develop that relationship with all four of them. The one thing about our midwives that I really like, though, is because they have worked in such varied settings, they really do have a gift of being able to meet people where they are, establish a relationship pretty quickly with folks, and just be able to minister and serve them in whatever capacity is appropriate at the time. And so we do have people that occasionally haven't had much opportunity to meet a midwife that might be at their birth. And we always wish that that weren't the case, but when that does occur, the midwives put a lot of extra effort into really trying to build that trust at the time. The other thing we should talk about now is rescheduling appointments.
That's a good. I was going to ask, what's the availability of
Yeah.
appointments?
So Kelly, you want to talk a little bit about that?
Sure. So we will do our best to accommodate your schedule as much as possible, but that is not always going to happen. And with our call schedule as it is, we have our schedule set up that occasionally the midwife who is on call for the day is also scheduled to see patients. When that is the case and we have a woman come in labor, we will reschedule her office day. And because it is a reality of our schedule, we do ask our patients to strongly consider this aspect of our practice before making your decision to come here. I like to say that every person should be prepared to have their appointment rescheduled at the last minute at least once. We do have some unfortunate clients who seem to be the target of that experience, who have that happen more than once in a pregnancy, but it is a reality of our practice. And a phrase you'll hear tossed around a lot with us is that birth is unpredictable. And because birth is unpredictable, we give you as much notice as we have when we have to reschedule. So we do our best to accommodate your request, and we also ask that you show some flexibility with your scheduling as well. Our office is open Monday through Friday, 9 to 5. We see our first appointment at 9 and our last appointment at 4:30. So that is a bigger convenience than some offices offer. But yeah, flexibility is key for all of us here when it comes to appointments.
And with that being said, I also want to reference back what, remember the definition of the midwife is with woman. So our first priority on any given day where someone is in labor is to make sure that she has the support, that face-to-face, relationship and support from the midwife and the nurse when she is needing it. Some labors are such that the midwife could still see a few people in the office. She might take them in the back and see them in the birth center part. But once the mother's labor gets to the level where the midwife's presence is imperative, everything else just has to go by the wayside. Occasionally, another midwife might have the ability to see some folks, but that's not something that we can guarantee. If somebody's living far away, we really try to take that into consideration, because we've had people that have come to the birth center that live some distance away. Some even live out of state. And so if they're on the schedule, we do everything we can to give them as much notice as possible. If they've already left and they're en route to the birth center, then it's a much bigger challenge, but we do everything we can. And our midwives are really good about taking that into consideration. If somebody is a person that needs more support, and missing that date is going to be really noteworthy, as far as timelines and whatnot, then the midwives are aware of that and they do what they can to accommodate that. It may mean that that person waits longer for their visit, or the midwives will then look at the schedule of when they can reschedule that person. Our midwives are very dedicated, and occasionally they come in even when they're not scheduled to be in the office to accommodate those women that absolutely have to be seen. But juggling our schedule is quite a challenge, and I can just say that Kelly and our front desk coordinator, client care coordinator, Anita, work really hard every day to make that schedule work and to try to do all they can to accommodate needs. But we just let you know that we have to live in a world of unpredictability, and to some degree our folks here have to too. So we just ask for your patience and we ask for your flexibility. And if that's not something that your life can accommodate, your work can handle, then you have to take that into full consideration as you're making your decision as to whether you want to choose this as a place to have your baby.
Yeah. How soon can I start care at the birth center?
We recommend that you come before the end of the first trimester. Some folks are really eager, they're really excited, they might be scared. Some folks might have a history of a miscarriage and they're especially wanting to come early. And so under normal circumstances, we don't really have a specific recommendation. We say that it's best to come before the end of your first trimester. Just to give you a little, insight into what happens in those first few weeks, though, there's not a lot for us to look at. We don't do those ultrasounds here, and so we would be referring people to Mayhec if they wanted an early ultrasound. We can't hear the heartbeat with a handheld Doppler until you're further along. We can take your history and we can gather your, draw your labs, just give you a lot of advice. But as far as physical parameters, there's not a lot to be done before, you get a little bit further along. So the optimal time to come as far as getting all of that taken care of and listen to the heartbeat is about 11 to 12 weeks. If somebody's having any problems at all, if you're nauseous, vomiting, there's something wrong that you're just really worried about, if you're having any bleeding or anything like that, then reaching out is definitely, something that is expected. But just keep all that in mind. Having said that, as far as the pandemic COVID-19 recommendations, they have declared that pregnancy is considered a high-risk condition now. And so we don't want our folks getting out and about much. And so for that reason, we are strongly suggesting that pregnant women be very much social distancing and not going out for anything but essential appointments in their first trimester. There's a lot of organ development and things like that that are occurring in those weeks preceding 11 weeks. And so we don't want you to be exposed unnecessarily. But we still want to hear from you, so don't hesitate to call us.
Yep. Do I have to take childbirth education classes?
Yes. If you've never had a baby before, we want you to be fully prepared, not only for birthing in the birth center, but also for birth in general. There's so much that can be gained by taking childbirth education, and we've got some really good options in our area. We're very blessed at having a really robust childbirth education community here, and so we would recommend that you check those out. There are some online programs that you can do. In fact, right now, a lot of the in-person childbirth classes are switching to a virtual format, just like we're having to do today anyhow. But it's very important. We actually require, especially all first-time parents, to take a series of childbirth ed. For second-time moms, it's very helpful to do a refresher course. There's some boot camp operations that just do it all in a big chunk of time, or you can stretch it out into a mini series or take a full series if you like. Our midwives strongly recommend folks that have given birth previously in the hospital or have had the use of an epidural in labor to take childbirth classes again.
Do I need to write a birth plan?
Most childbirth education classes include that exercise as part of their series, and the midwives like to see the birth plan. Now keep in mind, they're going to do everything they can to honor those things that are laid out there. Most of what you would think of, they normally do anyhow, but there are sometimes some family preferences, some religious preferences, or cultural things that we need to be aware of. In the event that there's any kind of medical emergency, though, we have to just tend to that as a first priority, and we'll try to do everything we can to still maintain the spirit of the birth plan. However, it might have to go by the wayside if there's no other option.
Right. So this is a big one. What happens when I go into labor? Who do I call, and who can I bring with me?
Okay. So, labor is very unpredictable. As you're hearing Kelly say and me say, we're using that unpredictable word pretty frequently.
Mm-hmm.
Birth is mysterious. It's magical. It's meant to be mysterious no matter how much we've studied it, no matter how much that wisdom has been passed down from generation to generation, no matter how much research is being done, it's still mysterious. And so we don't know exactly when anyone's going to go into labor. We don't know how their labor is going to progress, what kind of type of labor is going to happen. And so the midwife will talk to you, as well as in childbirth classes, you'll be learning about the signs and symptoms to report as you get closer to the due date. The midwife and you will make a plan. And as you get closer, there may be some warning signs that indicate that you could go into labor, pretty soon. You kind of go up on our front burner of like, we're looking out for you. But the midwife will let you know how you could get in touch with her. Our midwives being on call 24/7, there's a special phone line dedicated to reaching the midwife anytime someone needs to talk to a midwife. And so that will become more and more discussed with you as you get closer. And so when you feel like you're having some questions about whether this is labor, you call the midwife. She and you discuss what's happening. And we always like to talk to the mom, because frequently the mom doesn't want to talk on the phone, and so family members, the partner, calls instead. But there's some very subtle indicators in the mother's voice, in the way the mother describes what's happening to her that are strong indicators to us of some signs that we can go on as to how she sounds with regard to what place in labor she might be, or whether she's not in labor at all. Some labors start and stop over a long period of time. Some labors just are slow all the way through. Some are very straightforward, and some are lickety-split fast. And so no midwife can predict how it's going to go. Even for our moms that have birthed before and maybe had a certain type of birth, that doesn't mean they're going to have that same type of birth with the next baby. And so every birth is different. Every labor is different. And so it's very important for you to have that open line of communications towards the end of pregnancy. So you're going to have that call line information, and you will call, and the midwife on call will answer you. And you and she will begin to make a plan. That plan may include calling her back, at a specific time, advice as to some things to do during that time, or to go back to bed and sleep, what kind of things to report to her. And so as that plan develops, you will be in more frequent contact with the midwife. And you and the midwife decide when to come to the birth center. Now, we're not sitting here all the time 24/7 at the birth center just waiting for people to come in. When no one's in labor, then that means that at night, no one's at the birth center. So we want our families to call the midwife in plenty of time so that the midwife can get ready and to get out of her house and get over here. Most of our midwives live very close by the birth center, but you may need some time to get ready too. So we don't want our folks waiting too long. And when you all have agreed to come, then that's when you come, and the midwife and the nurse meet you here, and then, we take it from there.
Who can I bring with me?
Under normal situations, outside of the COVID-19 pandemic, your birth party is your choice as to who you want to have here. We add some cautions to that. They are your guests. This is the birth center. It's your birth. However, we ask you to think very carefully about who you want to have with you for an extended period of time, in any kind of type of setting where you might need a wide array of support. You might be clothed or not clothed. You may be making the normal, natural sounds of labor. You may be bonding with your partner. And so it's very important that you consider who else you want to include for what is a really intimate event. Some people can birth very normally with a lot of people there, and other people just can't. They really need a lot of privacy. So it's a decision that you need to take really carefully. Don't invite someone to your birth party that is not supportive of you and your partner and what your plans are, is not supportive of you birthing at the birth center. Those folks would be better supporting you from home. And should they come, they can often become less comfortable here, and they can try to intervene on your plans and encourage you to do something else. So it's not a good idea to have anyone that is not really close to you in this type of experience come with you to the birth. Under normal situations, we encourage families to bring children if they have kids that are interested in wanting to be there, if they're really prepared for what they're going to witness, how they're going to be entertained during what may be a very, very boring time for them. We require anyone that's going to bring children to the birth to also have a person separate from the partner to take care of the child during the course of the labor and the birth. That way they can be taken out if they're hungry, if they're tired, or if they're just distracting because they're overwhelmed with the situation. And sometimes it's best for kids to stay at home and not be at the birth at all. And sometimes it's fine for them to be at the birth, but they may find labor too hard to sit through. So there's a lot of variables with that. And the midwives will discuss that with you as you get closer as to who you want to have at your birth and whether or not they'd be a good person to have. However, that's all how we normally do it. And as of the past couple weeks, we've had to rethink all that. And again, we've had to look at some really harsh restrictions that limit the number of people you can have at your birth. And so I wanted to go over what we normally do. What is the birth center model, the midwifery model of care? But now to say that for the period of the COVID-19 epidemic, our family waiting area is closed to everyone. And so no one can wait at the birth center that's not an active party of the birth team. We ask you to strongly pare down your birth team to your partner and a support person. Be very, very discriminating about who that support person really is. It's just really important that they be an active part of your birth team. We don't want anyone on the birth team leaving the room for any extended time. If they have to use the bathroom, of course, that's great. But if they need to take a break longer than that, then they either need to go to their car or they may have to leave for a while. We are really trying to protect the birth center environment from the spread of this virus, and it's really important that we protect our families and our staff. So that's why we've had to enact these restrictions. It includes kids. You can't bring any children to the birth center, not for the birth, not after the birth. we'll talk in a little bit about how long you stay at the birth center, and so it is a shorter stay, and so you'll be bringing the baby home, and siblings and family members can then have that special moment in the home where it's more insulated and where it's more protected. So until the pandemic is over, those are the restrictions we're having to make for now.
Are there any supplies that I need to bring with me to the birth center?
Yes. Oh, let's back up for a minute
Sure.
and talk about other people at the birth. So
Okay.
this is a good time to talk about doulas.
Oh, yeah, we love doulas.
So doulas are a part of the healthcare team, and so we don't limit doulas from being able to come here and support their clients. All of the folks that enter the birth center will have to undergo sort of a health screening, list of questions that, do you have a fever? Have you had a runny nose? Have you had a cough? Have you been traveling? Those kind of things that all facilities are really asking about now, and a temperature check. Please think very, very carefully about whether you could be exposed or not prior to entering the birth center. And so if there is any of that has occurred with any one of your birth team, then we would ask that you make some different plans for that. We will be really drawing closely to our moms that are getting to be late in pregnancy, and really, querying them and wanting to talk with them if they have felt that there's been any exposure whatsoever. But as far as, doulas go, they are welcome, and they're not part of the one or two people that you can have. The doulas are their own practices, and so they're not employed by the birth center, and they're not contracted through us. They're privately hired by the family. So,
any supplies?
yes. So the midwives will give you a list of supplies that's good for you to bring. They're mainly things to make your life more comfortable while you're in labor. We're going to have the basic supplies here at the birth center for managing the birth. But, as far as things that are going to make your life more comfortable, then we will give you a list of things of what those can be. The biggest thing, the most important thing, next to having like layers of clothing that you can put on and off if you're the partner or members of the birth party that are going to be there, is food.
Mm-hmm.
We have light refreshments for the mom in labor, and we believe in our moms being well hydrated, well fed along the way. Those type of food choices tend to be, really light on the stomach. We like to refer to them almost like picnic fare. Women are usually not real jazzed about a whole big meal in the middle of labor, though there's always the ones that might do that as well. But we have light refreshments available for the mother. Partners, other support people really are on their own, so we ask that you bring food with you for them. And so, making a little picnic basket that you can, dip into and keep your energies up as well. It's very important that the whole birth party remain well hydrated and well fed throughout the course of the labor. I want to take a minute to talk a little bit about placentas, which it doesn't seem like might be in with the supplies, but a lot of folks want to take their placenta home and do some other things with it, maybe plant a tree or put a place in the garden where it's nearby and fertilizes the soil. They may want to do some art projects, inking the outline of the placenta. Some people might want to do encapsulation of their placenta as a healing modality. And so for those of you that want to take your placenta home, we ask that you bring a cooler, a separate cooler with ice in it. And after the birth, if that's what you choose, then we will have that put in your cooler, and it will stay with your things. If you leave the birth center and don't take your placenta with you, then your placenta will be disposed of like medical waste. We can't keep any placentas in the birth center.
All right. So I know that you can't do epidurals here at the birth center. So what do you do for pain relief if you're not doing an epidural?
Okay, so like I said earlier, When you're having a birth center birth, you really are preparing to have a home birth, only you're planning to come to our house to have your baby. We can't do epidurals at the birth center. It's not safe. An epidural is a very complex procedure, and so it has all sorts of medical interventions that go with it in order for the epidural to be done safely. Epidurals can be a wonderful tool when it's necessary, and so, women that may need to have an epidural at the birth center, can discuss that while they're in labor. And if there needs to be an epidural used, then we will go up to Mission Hospital and proceed on with the birth with the use of an epidural. But at the birth center, we cannot use any epidurals. We can't use any strong sedation. You are having, for the most part, what we consider a natural vaginal delivery at the birth center. Now, that doesn't mean that you're just stuck on your own, tough it out, sister, anything like that. Again, the word midwife means with woman. And so midwives are trained. Midwives' philosophy is to provide that labor support for women in labor. So what does it consist of? What does a midwife do? What does a doula do? They believe very strongly in physiological labor, how the body normally is made to be able to have the labor progress in a way that the baby will get out naturally and normally. And so there's a lot of things that we can do to enhance the body's ability to do that by watching how the mother's responding to her contractions. We love to use hydrotherapy. We call it an aquadural, our water epidural. Water is known to help relax the mother, and so our mothers have access to our birthing tubs. Each birthing room has a birthing tub in it. We also have a wonderful shower with a bench seating in there. So some moms might not like to be in the tub, but they might like to be in the shower. And so that helps a lot, along with the support and the encouragement of your birth team. Now, having said that, not everybody that wants an epidural or aquadural will get a water birth. And the reason for that is not anything to do with your care provider, whether you birth in a birth center or at home or even at a hospital that does water births. The majority of women that actually plan a water birth don't deliver in the water. And the reason for that is because they don't like it. Some people really imagine being in this wonderful, relaxing setting, soaking in the tub, and then they get in, and it's just not for them. Also, do you like to take a bath for 9 hours? I love baths, but I don't like to be in the water for hours and hours, And so that happens in labor too. If the water is relaxing the mom so much that the labor is actually backing off, the contractions are getting less and less sufficient, the labor may be stalling or stopping, then she may need a little gravity and it may be time for her to get out. So some women get in and get out and back in again throughout the course of their labor, and other women, it doesn't appeal to them. They know the minute they get to the birth center that they thought they were going to be interested in water, but now they're not. It's totally up to you. We use it as a tool, and we ask you to be flexible about that tool. We have 3 very comfortable tubs. They are vinyl inflatable tubs, and each of them has its own disposable liner that lines it, that is changed for every person getting in. You can't have hot water in the tub. It's very, very tepid in its temperature because we don't want to elevate the temperature of the baby by getting the mother too hot. But our moms are usually pretty hot just from all the work they're doing in labor, so it doesn't feel too cold. Other things that midwives do are position changes. It may be really helpful to utilize birth balls and different things to sit on. We have lots of different creative ways that mothers can get into all sorts of positions to go through labor. This is where the support of the doula is also an added benefit. So the midwives and the doulas have a lot of little tricks up their sleeve to help mothers be able to navigate the process of labor, feeling totally supported and being able to deal with the sensations in a way that is not requiring them to move to the hospital for an epidural.
All right, so I know that I'm preparing for a low intervention birth, so that makes me think midwives can offer some interventions. What can midwives do?
Yeah, we can offer some interventions. Now, keep in mind that labor, the range of normal in labor is quite wide. And so, even if things aren't going totally picture perfect along a certain bell curve of what, data would indicate, there's lots of variations to that. And labor moves at its own pace. And for some moms, they may not be able to rest when labor is not yet building up to a really active place, but it's still making them lose sleep and feeling degrees of discomfort. Oftentimes this is caused by the baby just not quite lined up in the pelvis in a way that's helping labor to just progress. And the baby has to find its own way. There's lots of ways that we can gently intervene with position changes to help the baby find its own way. There's more involved ways with the use of some techniques that we have learned from indigenous midwives in the Central Americas, such as using a shawl in various ways to bind the belly or to cradle the belly in ways and do little movements, almost like dance movements with it to encourage the baby into a different position. That shawl is referred to in indigenous cultures as a rebozo, and we have one of those in every room, and every one of our midwives is skilled in all these different midwifery tricks to help to encourage babies into a good, healthy position that's helpful for the mom and for them to get out. But sometimes our moms just get tired, and in the case where labor hasn't really been progressing, then the midwife can use some mild medications to help the mother get sleep. These are not things that can be administered as labor gets further along. These are things that are meant to help the mother get rest before she's going to be called upon to do her most strongest work. So that's an intervention that we can have. If somebody's really nauseous or if they're dehydrated, we do have the use of IVs. Now, at the birth center, IVs are not routine. I gave birth during a time where we had to be strapped to the bed and we were required to have an IV hooked up the entire time we were in labor. That is not part of midwifery model or birth center model of care. So we don't use IVs routinely. But sometimes they can be really optimal in helping the mother give some recovery if she's been dehydrated and not feeling well in that way. So we have that intervention. As far as others, we don't do any vacuum deliveries here, of course, no forceps deliveries, but we do just have a lot of midwifery tricks that in of themselves might be interventions because we are helping, we are intervening. Some of those might be the herbs and the homeopathics and essential oils. Midwives are all trained really specifically to utilize those therapies during the course of pregnancy, labor, delivery, and the postpartum period. And so there's some of those remedies that are very helpful to assist in helping labors to kind of regulate into a good labor pattern. But if the family is not familiar with them, if they are uncomfortable with them, then we're not going to utilize those. After the birth, we do have Pitocin. We do have anti-hemorrhage medication, the same type of medication that is available at the hospital. We have here at the birth center, and so we can manage hemorrhages here for the most part without having to transport. Of course, our first and foremost priority is always the safety of the mother or the baby. So we're going to take that really seriously always. We're going to be monitoring the baby with a handheld Doppler, and we utilize that tool as a way to enhance the mother's ability to move around freely and to be able to not be, tied down to a machine. In fact, the standards of the birth center, the Commission for the Accreditation of Birth Centers, states that if a mother has to be put on a continuous monitor, then she's really too high risk to be at the birth center. So while we do have a monitor in the prenatal part of the birth center, we do not utilize it at all during labor. So we monitor heart rates very carefully with the Doppler, and we utilize the standards for fetal heart rate auscultation that are set in, regular protocol. That tends to be that we listen every 30 minutes in early active labor, and then we start to increase in frequency with those monitorings once labor progresses further. As we get towards pushing, then we may be listening every 5 to 15 minutes, depending upon what's happening. And of course, we will listen as often as we need to, should there be any indicators that we need to listen more closely. One of the things we're looking for when we do listen to the heart rate is how the baby's handling a contraction. So sometimes we will have to keep the Doppler on during a contraction so that we can see how the baby's responding. And then after the contraction's over, how the baby responds to that. And so by listening to the patterns that we hear, we can determine whether or not we're still remaining in an area that's very, very reassuring. Some other things that we do is people ask about breaking water. We don't believe in breaking water unless there's a medical indication to do so. We take that, again, very seriously because the water is often there for a reason. It provides cushioning to the baby's head, and the baby may need that cushioning as it's maneuvering its way through the birth canal. Sometimes, though, breaking the water can be a very good thing. If that's what was normally going to happen anyhow next, then we can sometimes save the mother more time by breaking the water and just getting that out of the way and allowing the head to come down and fully apply on the cervix, encouraging labor to come on more. But as far as inducing labor with breaking water, we don't do that at the birth center. And we're very cautious about what types of clinical benchmarks need to be present before we would feel that it would be safe to do it at the birth center. But occasionally we do, and sometimes it's the very best thing. At the birth center and with the midwifery model of care and the birth center model of care, our commitment to shared decision making, no one is ever going to break your water without your permission. This is something that is very important. And so no midwife will just go in whether you want her to or not and break her water. Occasionally, if the water is ready to break anyhow, a midwife might be performing a vaginal exam and the water may break under her hands, but not because she's done anything interventive while she's in there to encourage that. Sometimes the water is just ready to break. So while we're talking about vaginal exams, it's a good idea to talk about what's normal and what you can expect in labor. It is not particularly useful to do a lot of vaginal exams. In years back, people did a whole lot of them, and it was considered a way to really keep track of this, dilatation process with the cervix and whatnot. And so you hear a lot of people talking about how far someone's cervix is dilated, how much the cervix is getting ready prior to going into labor during the course of their prenatal care. It's not necessarily very helpful, and in some ways it can actually be more stressful for the mother to have that focus on there. So the midwives will talk to you about that during the course of your prenatal care. If you have a reason to be checked, if there's a medical indication that it's important for you to be checked, then we will, of course, do a vaginal exam. It's not that we're opposed to doing one, but we want to have a reason for why it's worth your while to choose to have that, And during labor, there's oftentimes, ways that we can discern how far along a woman is moving by just how she's behaving. the things that are happening to her body, the sounds she's making, the way she's coping with her contractions, what's happening between contractions. There's all kinds of little signs that we pay really close attention to. And, we don't feel the need to be checking that cervix. Of course, if there's any medical indication whatsoever, and sometimes there is, then we will ask if it's okay to check you. In the event that there's an emergency developing, we may need to check you. And in that case, things may happen kind of quickly, and you might be very in a place of kind of like mental, kind of a confusing environment. And you may not hear everything that's being said to you just because you're focusing so much on what's going on. But the midwives take informed consent and just shared decision making very carefully. So we won't be just giving you, administering things to you or doing things to you without your consent. That's very important. We have the ability to repair lacerations should they happen, and during the actual birth, then the midwives do a lot to prevent tears. Midwives are kind of known for that, and midwives tend to have fewer tears than birthing in more conservative or conventional settings. Some of the ways that you can prevent tears are by using warm compresses in labor, especially right at the very end. We use arnica oil to the area and have pushing occur in a way that's not putting undue pressure on areas of the perineum where that pressure shouldn't be going. And so a lot of that is assisted by the position of the mother as well. So the midwives do some gentle support of the perineum as the baby's emerging through. And with all those things, then your likelihood of having a tear is significantly reduced. But it's not really up to the midwife whether or not you tear or not. There's a lot of factors. It might have to do with the baby, which way the baby's head has positioned itself, where the shoulders and the arms have lined up for delivery, as well as the integrity of the mother's tissues in that area of her body that haven't been put under that kind of experience prior. And so it's no one's fault if someone tears. We don't do routine episiotomies ever. There may be a very occasional rare occurrence where an episiotomy is needed, but even in that event, midwives usually prefer a snip to an actual cut, and repairs are easier done usually with a tear than with a cut. And so the midwife will examine that area after the birth, and she will decide what type of repair is necessary, and we can do most repairs here at the birth center with the utilization of lidocaine. After the birth, the baby comes right up on the mom. The midwife and the mother, or the midwife and the nurse, are assessing the baby right away. They're looking for indications that the baby is transitioning and that the cord is still functioning. We are very familiar and supportive of delayed cord cutting. And so, anyone you want to have cut the cord is perfectly able to do that. In some occasions, delayed cord clamping doesn't necessarily have to mean all the way with, like 20, 30, 40 minutes of delayed cord clamping. When the majority of the baby's blood has been received by the baby, then it's fine to cut the cord. But there's no hurry on our part to do that unless there's a real medical indication that we need to cut the cord for some reason, and that isn't very common.
All right, so here is probably next to what happens if the rooms are full, the second most commonly asked question. What if I or my baby need to go to the hospital?
Okay, so most transfers from out of hospital setting, and that's either home or hospital, occur for the same reason, and it's non-emergent. And that is, you've got a tired mama. Oftentimes it's a first-time mama, but it could be, a mom that's given birth before. and she's exhausted. And this is no fault of anyone. It's not her fault. It's not her partner or birth party's fault. It's not the midwife's fault. You know, it just is the way it is. She's just tired, and no matter how many support techniques are utilized or how many resources are given to it, then she's just tired. Some moms might change their mind. They might really decide after they're in a full chance of labor that they want to go to the hospital and have an epidural. And if that happens, that is fine with us. We honor the mother's decision always. There is no right or wrong way to have a baby. And if the birth center setting is not the best for the mother when she is in labor, then we honor that and we accompany her to the labor or to the birth, to the hospital from the birth center. And then we return to whatever type of birth is appropriate in the hospital setting. And some of our moms have absolutely beautiful births with the use of an epidural in the hospital. And the midwives do everything they can to pull out the stops to ensure that they have a really great experience and that we can lessen the interventions that are necessary depending upon the reason why we went there. And so how things go at the hospital is very dependent upon the reason why we're going. But first and foremost, we want moms to understand that this isn't something that, they have to decide ahead of time. If you're planning a birth center birth, you're making a commitment to have a birth at the birth center without the use of an epidural. But if when you get in labor, you feel the need to have one, support measures are not enough for you. You may just have some concerns that haven't come to light before. Then the midwife will take you to the hospital. Some women may express a desire to go to the hospital when really they're asking for more support. And there's times during the labor process where that is more likely to happen than others. And so if it's happening during a transition period, during kind of the wild woman time, as the cervix is just finishing opening its last little bit, and then the mother's going to be going into second stage as the baby moves down and she's pushing. Well, that is a common time for moms to say, I want to go to the hospital. What the midwife will do then is she will really talk to her about what she needs. And if she needs to go to the hospital, then she will honor that. If what she needed was just people closer by her face, breathing with her for every contraction, or maybe back in the water, or maybe in the shower, pressing on her back a certain way, then a lot of times the midwife can help her get over the hump of that time period, and she's really not wanting to go to the hospital. She's just needing some help getting through that phase. And so the midwives are really good about being able to recognize the differences in that. But truly, no matter what the mother has said prenatally, no matter what kind of deal she might have cut with her partner about, like, whatever I do, don't let me go, the mother calls the shots in labor, and she knows what's best for her. And so we will always honor her decision. So that's the most common reason. It's non-emergent. We can go in our own cars. Sometimes the midwife will go with the family. Sometimes the families will go in separate cars with the midwife, following them. Once they get to the hospital, the midwife will admit them into the hospital. Remember, our midwives have full practice privileges at Mission Hospital, and so we can make a very seamless transition from the birth center into the hospital. Once we're there, though, the MAHEC OB and Family Service team, they are our collaborating physicians. And so we consult with them. We let them know what has occurred along the way. We review with them a suggested plan of care. And then we continue managing the situation in the hospital room with, the same birth party that was here if it's appropriate. And go on to have whatever kind of labor and birth process is going to occur after that. We're usually assigned a hospital nurse. Hopefully the midwife and the nurse will be able to get on the same page pretty quickly. At the hospital, the midwife still is your provider. Most of the time she's still going to deliver the baby. If there needs to be a surgical intervention or a mechanical intervention in some way, then one of the MAHEC obstetricians will become part of that team, and the midwife will then be in the role of patient advocate and support for you. But, the midwife stays with you throughout, and most of the time the midwife can still deliver the baby. So that's what happens if it's a non-emergent. If there is an emergency, and those would most likely be categorized with degrees of abnormalities we might hear in the heartbeat. Remember, our first and foremost priority is always going to be the safety of the mother and the baby. And so if we're hearing heart rate patterns that are not reassuring, the very first thing we're going to do is switch the mom's position, and 9 times out of 10, that resolves the whole thing. It's just the way the mom was lying down, the baby was lying in a certain way, and it was just putting some pressure on the cord, and it was reflected in the heart tones. And it's a temporary situation, and it doesn't mean the baby's under any kind of stress. And so if that remedies very quickly, then we still monitor with more scrutiny to make sure that that's all that we're hearing. But it doesn't mean we need to go to the hospital. However, if that does not resolve, like almost immediately, and if it continues to be any kind of popping up incident during the birth, then we're going to go to the hospital. We would prefer to be in the hospital earlier than late, because our first priority is the mother and the baby's safety. Second to that is the experience, and we feel that we do not have to compromise the experience at all in order to maximize safety. In that case, we would call EMS. They usually come in about 5 minutes. We've got a separate EMS entranceway, and they would come in, and the midwife would be quite involved with the EMT team, and they would transport the mother to the hospital, and the midwife sometimes is able to go in the ambulance, most of the time can go in the ambulance, but if not, she would follow immediately behind. Phone calls would be made simultaneously to the labor and delivery, so that they would be anticipating our arrival and could meet us there. And then the mom would be taken right up to labor and delivery, and then both the midwife and the MAHEC L&D team would be ready to assess the situation and decide on a plan of care, and it would depend upon what that was, how interventive it would get. Sometimes the midwife would still be able to be the provider, and occasionally it might result in a C-section, and the midwife would be there for support. So in the event that the baby needs help, most babies when they come out have a period of transition that's built in very, very naturally to their physiologic development. So the baby comes out, comes right up on mom. Midwife and nurse are assessing the baby right away. There's specific benchmarks that occur for the baby transitioning to new life. And if they see that the baby's not making that transition, then they intervene appropriately for what signs they're seeing. Most babies come around if they're just a little stunned and they haven't breathed or taken a breath in the regular course of time. Keep in mind the cord is usually still pulsing, so the baby's getting oxygen from the cord. But should there be some more intervention that needs to occur with a bag and a mask ventilation, then the midwives and nurses are all certified in neonatal resuscitation. They're certified in basic life support. The whole birth team on a regular basis reviews emergency drills so that if something should happen at the birth center, they're prepared for the complications that are likely to occur there. And they're ready and equipped with everything that we need to utilize at the birth center to make that passageway safer. Now, we have a really good relationship with the NICU. We really appreciate their support of the birth center. They have met with us. They have visited the birth center. They have viewed our equipment to make sure that we had everything at our disposal that was good for us to have in this setting. They have done resuscitation drills with us, and so we feel really confident in our way to work collaboratively with them. So if we need to bring a baby up there for any reason, then we are going to call NICU right away. They usually meet us in the ER. We're transporting via ambulance with the midwife going along and instructing the team on any kind of support for the baby that's needed. And then once we arrive, the NICU team takes over. You know, how often does this happen? It's a good time to talk about our statistics in general. So keep in mind our standards of only having low risk moms here with normal pregnancies that have gone on normally along the course of the way and trained people means that at the end of the mother's care, we're not going to have we're not going to have mothers that have high blood pressure. We're not going to have mothers that are insulin diabetic. We're not going to have mothers that are very overdue or really premature. We're not going to have mothers that are living a lifestyle that is contributing to the baby being put into an increased stress situation. If there's any way that there could have been any intervention or knowledge about that, we would have provided whatever support we could to encourage an environment where the mother could become more healthy. And if she couldn't, then a referral already would have been made for us to plan for a hospital birth. So when you start to limit all of those factors, as well as that we're not using medications that would have a sedating effect on the baby, then you really start to reduce the likelihood that a baby's going to come out here without having been enough warning that we would have time to go to the hospital should the heart tones be giving us an indicator. The likelihood of this happening at the birth center is very slim. However, if it does, we are prepared for it, and we are prepared to transport as soon as we possibly can and stabilize the baby en route. Sometimes the baby just needs a little bit of help, and if that's the case, then the baby just returns right to the mother's arms. We're going to watch the baby and the mother much more closely, to really make sure that the baby isn't having any kind of additional issues that would indicate that, yes, we do need to have more assistance there, and we don't need to go to the hospital. But if we've had to do a fair amount of resuscitation, then we're going to transport to the hospital. So women that develop conditions during the pregnancy that make it ill-advised for them to continue to plan to birth at the birth center, those women then have planned hospital births with our midwives. We can't offer planned hospital to the general public right now. We don't have enough midwives. We hope that maybe someday we could offer that additional service. But we do have that option available to the moms who are planning a birth center birth. But along the way, circumstances developed that they had conditions that put them out of that range of normal, so that being at the birth center was no longer advised and a hospital birth had to be planned. In that case, we walk that pathway with you, and the midwives will agree to serve you in the hospital to the fullest scope of their availability with their practice privileges. And most of the time we still get to deliver those babies in the hospital using our same midwifery model at the hospital. And if there's any way that we can even use our midwifery tricks, there's a photo circulating of one of our midwives actually standing up on a hospital bed using that shawl to do maneuvers with the mother to turn the baby's position to a more optimal one, then we'll pull out the stops whether we're at the birth center or the hospital too.
All right. I think that about summarizes the most frequently asked questions. As always, if you have more questions about our practice,
Postpartum.
Oh yes, how long does a couple stay?
Okay, so after the birth, what happens is that normal monitoring of the baby occurs for the first few hours. Babies stabilize really quickly after the birth if everything's gone well. So if we're remaining at the birth center, it means the baby's doing great. And so we closely monitor that baby for breathing issues and for maintaining its temperature and things like that with its vital signs that give us, reassurance that the baby's transitioning nicely. At the same time, we're monitoring the mother for bleeding. That's the main thing we're watching for with the mother. And so, as the mother and the baby adjust to life outside for each of them, then our assessments take a little bit of a different flavor. Initially, we're right up there, looking over the different benchmarks as they begin to occur. And after reassurance is more and more satisfied, then the birth circle begins to move back a little bit and allow that bonding time with the family, with the nurse and the midwife still there, still involved, still maintaining whatever surveillance from just a little bit of a step back, so that the parents can celebrate this magnificent event that's just happened and can marvel over the baby. After, usually in the first hour, we like to initiate breastfeeding if the baby can be encouraged to have that experience. And so the midwife and the nurse are very skilled and committed to helping facilitate that process. And, we may go in and out of the room a little bit and give the parents some privacy for short periods of time. And then about hour 2, the midwife will do a total newborn exam, head to toe assessment, checking the different parameters that indicate that the baby is doing very well. And that's the same type of newborn exam that they get in the hospital. There are some things that we offer at the birth center that are routine in the hospital setting, and that is the vitamin K and eye ointment prophylaxis. Both of them are things that we have available here at the birth center, and the midwife will talk to the parents both prenatally and then at the birth about what their purpose is and what the benefits are for them, and whether there's any real specific indicators in their family as to why any of those would be more recommended. And then the parents decide if they're going to agree to have those administered. If they choose not to, then we have them sign a waiver. And also some of our families bring their own oral vitamin K, and that's fine. They can have that administered at the birth center, but they must purchase that on their own and go out and be resourceful enough to get that by them, on their own. That's not something that we do. After everything is very stable, the mom's gotten up to pee, we've helped get her cleaned up, and the baby, skin to skin with the parents, and the room comfortable, the mom fed. Then the midwife will take a step back, and the nurse will become the main caregiver over the next several hours. So most folks are perfectly stable and ready to go home in 6 hours after the birth. That is the most common time people go home. We support early discharge because we know that families rest more in their own home than in our birth center. They have more privacy and they can rest better in their bed than in our bed. And so we encourage that discharge at 6 hours postpartum. If any of the benchmarks with the mother or the baby are not on track to meet the time parameter, then we will ask them to stay longer until we feel like that parameter has been reached. So it may be that they stay an extra hour or 2 hours till there's a lot of confidence that everything is going to be ready for the baby to transition and the mom to be okay back home in their own setting. If that has not occurred by a 12-hour time period, then that means that the baby needs to go. The baby or the mother need to transport to the hospital. It is so uncommon for there to be a reason that is medically indicated for the mother and the baby to remain at the birth center after 12 hours. And so that would mean that we were concerned enough that the mother and the baby needed to be moved into a more medicalized setting where there was just a lot more availability of extra team members for whatever the concern is at that time. So generally speaking, 6 hours, and the nurse would alert you as to the time that you were, it was looking like you would be ready to leave once things started to stabilize. Once you go home, then the nurse generally does a home visit sometime within the next day or so after the birth. It depends upon what time of day you birthed as to what day that will be on. We can do home visits within an hour's radius of the birth center. Now, if people live outside of Asheville and closer to that boundary, then it might be possible that you might not get your home visit as timely as you might have expected it. These factors depend upon whether or not there's another labor, because again, we've got to focus on the people that are having their birth. If there's no emergency that's precipitated you being at home, and so they may have to delay the home visit, or sometimes ask the family to come to the birth center and have their home visit at the birth center. Those folks that are over an hour away, we ask them to come in for that checkup. Things that are offered at that home visit are the newborn screening exams. They consist of a metabolic screen and a bilirubin screen. Most of our folks choose to have that. Those can be really important screening tests that have really profound implications if they're positive or negative. And so we support the families having those tests. However, again, with shared decision making, if you choose not to, then you sign a waiver, and we, of course, don't do those. The nurse will be evaluating how the mother's bleeding is, how she's adjusting to family life, whether there's needing any breastfeeding assistance that's needing, and we'll evaluate the baby's color, how much the baby weighs, all kinds of things with the baby. So it's a pretty comprehensive visit. After the home visit, then the nurse will call the family in the first week, usually a day or so after the home visit. If there's something that everybody's watching more closely, it may mean that the family comes in for more in-office visits during that first week. It just depends upon how it's all going. At 2 weeks, we want to see the mom for a 2-week checkup. For those that are going to have their baby still remain in our care, and this is a good time to talk about how babies are something that midwives can take care of for the first 28 days. And so we like to keep our couplets together, our mom and baby couplets, and they can be seen as a family unit at that 2-week visit where we weigh the baby. We also administer a hearing screen on the baby that day if the parents are agreeable. That's another screening test that's very helpful. And, just evaluate how the adjustment's going. After that visit, if everything's going well, then the final follow-up is at 6 weeks with the mother. And that involves an exam and a discussion about family planning and all sorts of things about, transitioning back to life after that. If there's any indicators of any kind of other issue, of course, there's more follow-ups, there's more phone calls, and there's more visits in. Also, we understand that the 4th trimester, the postpartum period, is so ignored in our culture, and we don't support that. But society does not afford the healthcare system ways to become much more involved in that. We do our best. We want to still maintain contact with folks, but we hope that through the advocacy of midwives that the 4th trimester can be better recognized as one that involves the need for a lot more care. As another topic, totally unrelated, the midwives have full prescriptive privileges. They have the ability to do GYN well woman care as well as primary care for our established patients. We have the ability to do family planning, and many women use us as their primary caregivers and receive their annual appointments here once they're no longer pregnant. So that's something you can consider for the future.
All right.
Anything else you can think of?
I would say not for clinical care. I think that's a good summary of what we offer here at the Birth Center. If you still have questions, please feel free to reach out to us. I am your best point of contact. Should put that on the screen there. My email is kheinerth@wncbirthcenter.com. Feel free to ask me any questions that you felt we didn't address in this video or that come up for you along the way, and I will make sure that we get them answered for you. There will be another video that gives a virtual tour of our facility, kind of give you a peek inside the rooms, and there will also be another another video on what your next steps are. So be sure to check those out as well.
Thank you for being patient and staying with us for this video. We know it's long. This is what we do at orientation, and so we don't want you to be missing out on any information that we normally go over. And we hope that we can return to our normal orientations in the future, so that we can welcome you more in person. Please know that if you need anything, you can reach out to us, and we'd be happy to answer any other questions. So thank you again, and have a great day, and please stay safe. Wash your hands, practice social distancing, and just know that we're thinking about you, we're caring for you, and hopefully we can get through this all together. Bye.